Brief announcements before we start. I miss you guys. Now that I'm going to see you once a week, it just doesn't seem right. But what else? Oh, homework has been posted. So there's some questions, very cut and dried questions about medications used for arthritis and inflammation. And you just have to look up the answers. They're all of the answers are in chapter 12 of the Gladson Pharmacology book, right? And just type that up, and you can either email it to me or bring a hard copy and give it to me at the start of class next Friday, okay? I actually will see you twice next week because I'm super excited, as I am every year, about our trip to the Mutter Museum, coupled with extra good news about the trip to the Mutter Museum this year, in that based on some feedback I received and totally appreciate and totally get, and unlike some things that I can't do anything about, this was something that I could do something about, so there's going to be no admission charge for you for the Mutter Museum. The program is going to have that covered for you, so all you have to do is figure out a way to get yourselves into Philadelphia, okay? And absolutely, and I'm glad we could resolve that and improve that situation a little bit for you guys. Okay, so let's look at, it's a little warm in this room, although it's definitely feeling like fall outside, right? Just like a day ago, it was hot and humid and disgusting, and suddenly it's like fall, cold, chilly, and all that. Okay, so here's an x-ray, right? Pretty much straightforward AP view. You can, I hope, pretty quickly pick out what joint this is. Anybody? Did somebody say hip? No. Okay. No, it's not the metacarpal phalangeal joint. No. It's the shoulder joint, of course. And there are a couple things that are abnormal. If you peek ahead in the slides or in the notes, you'll see what they are. But to help you visualize those abnormalities, we're going to just put some arrows here into the figure. And there's two different abnormalities, and the arrows are pointing to those things. So the yellow arrow is just pointing to something that we should not see, right? In a normal shoulder x-ray, this little sort of crescent or curved bar, right, that is a little bit radio opaque should not be here, okay? And then furthermore, we see some bony sclerosis, some increased bone density and increased calcification right here. And what is this joint line, obviously? What is this joint? The AC joint. Now we can see at the top of the AC joint, we have a nice separation, right? There's a little bit of black space cartilage between the two ends of the opposing bones. But as we get down to the bottom, that space virtually disappears, and it looks like the bones are almost touching each other, right where those pink arrows are. So what are those abnormalities on this particular radiograph? This is someone that has intermittent right shoulder pain, and what did we see? There was calcific tendinitis of the right supraspinatus tendon and osteophytes or bone spurs in the lower margin of the right AC joint. So let's just sort of go back to them and look at them again. And there's the supraspinatus tendon, and you can see the supraspinatus muscle belly being back here, kind of merging into the tendon. At the distal end of the tendon, as it's approaching its insertion at the greater tuberosity, on an x-ray, we normally should not see that, right? Because it's a tendon. Tendons don't show up on x-rays, okay? But when it's calcified due to overuse, wear and tear, chronic degeneration or inflammation over time, the body's response, unfortunately, in this case, was to create some calcium deposits within the tendon, and they do show up on the x-ray. So that's calcific tendinitis of the supraspinatus tendon. And then right here, we can see the increased bone density, the lack of joint space because those bone spurs growing right into the joint space and creating some trouble for the AC joint. Okay. So this is there only one? There's 2 slides of this. Okay. This is a story of one of the JOSPT imaging studies. This is our other image of the week. And this is really an interesting story, so I'll tell you a little bit about this guy. He's a 20-year-old soldier in the Army with complaints of deep anterior left shoulder pain. Okay? The symptoms developed insidiously. Now, insidiously means he doesn't know why, right? There was no major injury. He didn't fall off the truck, right? Nothing happened in particular that can remember, but the symptoms have been developing over a year and a half now. He does feel that when he does intensive like weightlifting or overhead lifting activities, the symptoms get worse. And he's obviously been doing some very, very physical training as a result of being in the Army on an ongoing basis. Now, on examination, range of motion was limited in all directions and painful in all directions. His strength was okay. And the physical therapist wasn't really sure exactly what the diagnosis was. So all directions were somewhat limited in range of motion. It seemed like the guy was a little young to have osteoarthritis, right? Or arthritis in the shoulder joint that might explain limited range of motion in all directions. But the physical therapist thought, all right, well, it's clearly there is something going on with your shoulder joint. Let's see what happens if we do some joint mobilization and exercise. And just try some treatment, even though the diagnosis was a little unclear. And lo and behold, the guy didn't get any better. So the physical therapist does some treatment, pain's unchanged. And then after a few sessions of the physical therapy, the physical therapist said, okay, you really need to have an imaging study done because we don't know exactly what's going on. You're not responding to conservative care. So let's see what we get. So this is an X-ray of the patient's left shoulder. And what you can see are numerous radio-opaque loose bodies throughout the glenohumeral joint. All right, so I'll start pointing them out. The glenohumeral joint capsule coming down here, so we see loose bodies here, loose bodies in here. Just these extra sort of little like floating radio-opaque clouds that really shouldn't be there. That is was consistent with a diagnosis of something called synovial chondromatosis. Okay, what is synovial chondromatosis? Well, synovial, right? Remember the synovial membrane. So the deepest layer of a capsule of a joint is the synovial membrane. Okay, and in this case, in this disorder, what happens is that synovial membrane gets irritated, right? And it grows extra nodules. Those little extra nodules of synovial membrane break off and they calcify and then they start floating around inside the joint and they get in the way. And they cause limited range of motion and they cause pain with movement. Okay? Now, in addition to the X-ray, this was a T2-weighted axial MRI where you can also see these loose bodies. This is a different view, so this is sort of more of a transverse section. And you can see these various loose bodies just floating around inside the shoulder joint. So whenever this guy tried to move his shoulder, they would sort of interfere with normal motion, they would get in the way. All right? So what do you think the treatment was for this condition? Not necessarily by the physical therapist, but what did this guy need? Kai, what do you think? Surgery? Right. He needed arthroscopic surgery to basically go in and remove these things, right? And that's exactly what was done. So arthroscopically, a surgeon went in, simply removed the loose bodies. I think there were about 24 of them altogether, okay? And then after that, the patient went back to physical therapy now with basically the problem fixed surgically, and went into a gradual program of range of motion and strengthening. Within a few months was back to full duty military and not having any problems or symptoms in the shoulder. Okay? So why do you think this happened to begin with? Anybody want to take a stab at that? In like a 20-year-old male? Go ahead. What was the first thing you said? Poor movement patterns?
Yeah.
Yeah. So he might have had poor movement patterns. Maybe he had bad posture. Maybe he had a protracted shoulder. Maybe he had scapular dyskinesia and like problems with muscle control of his scapular rotation. That's a possibility. And coupled with that, though, is the fact that we know he's using it all the time. He's in the Army, he's in basic training. He's got to do lots of weightlifting, lots of overhead pushing. So if that chronic overuse, right, and all that stress on the joint, all that repetitive loading, right, possibly some repetitive stretching as well, maybe coupled with bad alignment or sort of bad muscular control of his scapula, it basically pissed off the shoulder joint, okay? And the shoulder joint can react to that in different ways. And in this case, what happened was the synovial membrane got irritated and inflamed, and in response to that, it just sort of became a little hyperplastic. It grew these nodules, and then those nodules just needed to do something, so they broke off and they calcified, and they got in the way. Right? Okay, so good. All right. Those were our images of the week. And this is a talk on inflammatory and infectious disorders of the musculoskeletal system. And the first thing, is what is our definition of an inflammatory disorder? So there will be some need for you guys to take some notes today. This is a broad, it's kind of obvious what the definition is. It's a broad category of diseases or conditions that are associated with or attributed to inflammation, right? There's an inflammatory component to these diseases or these disorders. Now, when you have inflammation, sometimes there's acute inflammation. And there are 5 cardinal signs of acute inflammation that might manifest in various proportions. You might see heat. So if it's the shoulder joint and it's acutely inflamed and you put your hand on it, it's going to feel warm, okay? Or the knee joint, or whatever the tissue is. There's going to be erythemia, which is just a fancy way of saying redness, right? There's going to be swelling, pain, and loss of function. Now, why do you see these things in someone with acute inflammation? Well, generally, the heat, the warmth, is due to vasodilation, right? Blood vessels in the area have dilated, so there's increased blood flow to the tissues, and that vasodilation, right, causes warmth. And you know, when you're vasodilated, you're warmer, right? If you go run 5 miles and you're completely vasodilated and all your arteries in your head are throbbing, right? And you're very hot and you're warmed up because you're part of that is because you're vasodilated. The redness or the erythemia comes also, that's what we just talked about, the vasodilation. The heat comes from vasodilation. The redness comes from vasodilation. The swelling is also related to the vasodilation, but the fact that there's exudate out of the vessels into the tissue, right? So normally you have a region of your body, a joint, your upper arm, whatever it is, and the fluids are contained in, the blood stays within your blood vessels, right? Your lymphatic fluid stays within your lymphatics. right? The fluids sort of stay where they're supposed to be. But when you have vasodilation, there's exudate through the vessel walls, so fluid now sort of leaching out into the tissues. And why is there pain when you have inflammation? Well, if you have increased swelling, that increased swelling is going to put pressure on things, on nerve endings.
Nociceptors.
Say again?
Nociceptors. Never mind.
Nociceptors. Yes, sorry, I just couldn't. That's okay. Yeah. The swelling is going to put pressure on nociceptors as well as other tissues in the area that maybe just aren't used to experiencing that. So there are mechanoreceptors in the connective tissues that might not be happy. There's nociceptors also that are going to possibly trigger pain. Okay. So we have that irritation of the nerve endings, plus we have the increased pressure on tissues. Now, why is there a loss of function? People who have an inflamed joint, they don't want to do as much with that joint, right? Well, that's because it hurts if they do it, right? When people are in pain, they might be muscle guarding, there might be some spasms, so there might be some protective spasm that is also limiting their function. So we have pain, protective spasm, or muscle guarding. And more chronically, if this went on for a very, very long period of time, there might be fibrosis or scarring or tissue destruction, right? If there's damage, right? Tissue destruction, and later on, fibrosis or scarring. And that could cause limited function as well. Okay. So inflammation is either acute, but sometimes it's not acute and it's chronic instead. Like it won't go away. Kind of like acute pain and chronic pain, right? So inflammation has these acute or chronic characteristics as well. Sometimes it sticks around. It doesn't go away completely, or there's some low level of it that just won't resolve. In chronic inflammation, we see a presence of lymphocytes and macrophages and plasma cells, proliferation of blood vessels, so new blood vessels growing in the area, new capillaries forming, proliferation of fibrosis, which is like scar tissue, disorganized connective tissue, tissue destruction, and that might be due to chronic inflammation locally or also low-grade inflammation that's occurring systemically throughout the whole body. Now, this is a slide I just wrote this morning, so it's not in your slide deck, but I did email it to you. If you have persistent, systemic, low-grade inflammation throughout your whole body, it is not a good thing, okay? Like inflammation has really become, in recent years, identified as just one of like the kind of this global health problem. Is linked to so many disorders and increases the risk of so many diseases. If you have systemic, persistent, low-grade inflammation throughout your body, right, you're at a greater risk for cardiovascular disease, for type 2 diabetes and other metabolic disorders, for muscle wasting, for dementia, for depression, and even for osteoarthritis. Now, what's the cause of persistent systemic low-grade inflammation? It could be immune disorders, exposure to toxins or chronic environmental stresses. Smoking is known to cause systemic inflammation. Chronic stress and anxiety can cause chronic inflammation and systemic inflammation throughout your body. So it's not good, ladies and gentlemen. It increases the risk for all these things. And if you have any of these diseases or disorders or conditions, naturally, they could lead to decreased activity levels and disability, right? So people with cardiovascular disease or arthritis, they're worried about their health. They're not feeling as well. They stop doing as much. They're not exercising as much. They're not as active. And guess what happens? Lessening your activity level, becoming more sedentary, exacerbates systemic inflammation. In fact, one thing that has been linked to systemic inflammation is a sedentary lifestyle without enough physical activity, without enough exercise, right? Which is exactly why we did the salsa warm-up this morning, right? So we didn't want to have any risk of worsening any systemic inflammation at the start of class today, so we got a little active. But if people are disabled, if they're not doing anything or as much, that's going to exacerbate their systemic inflammation even more. And then guess what? Any disease or condition that they have that is linked to inflammation can get worse. The disease or the condition gets worse, and then guess what? They become more disabled or less physically active, right? And it's a vicious cycle. So, fortunately, there are things that can be done to interrupt this vicious cycle, right? Or to prevent systemic inflammation. Exercise is known to have an anti-inflammatory effect, right? Healthy amounts of exercise and being physically active, right? Controlling your stress and anxiety, right? Maintaining healthy levels of serum cortisol, which is like a stress hormone. So if you have sort of a nice balance of your life, maybe you're doing a little meditation, you're getting some exercise, you're not smoking, you're eating a well-balanced diet that doesn't include too much red meat, for example, because high dietary intake of red meat is associated with increased levels of systemic inflammation, right? In certain individuals, eating a lot of dairy products is associated with increased levels of systemic inflammation. So there are things you can do to try to mitigate the systemic inflammatory level that does exist in some people. Okay. So, what actually causes inflammation to begin with? Well, we mentioned things like smoking or stress, right? But other things as well. So we have some additional causes here. Anytime you have an infection, there's going to be an inflammatory response. Certain disease processes, metabolic disorders, trauma, either a single macro trauma or repeated micro trauma over time. How does inflammation begin, right? So we sort of know the things that kind of cause it, like in a broad conceptual way, but like what actually happens to trigger it? Well, usually there's some sort of cell injury, right? There's something going on a cellular level. The cell might have a lack of blood supply to it. There could be ischemia. There's maybe an infectious agent that's disturbing the cell. It might be an immune system reaction in your body. So like hormonal reactions, endocrine imbalances going on that do something to trigger activity within the cell. There could be chemical factors like toxins or free radicals, reactive oxygen species, that sort of trigger the reaction of the cell. Even genetic factors are certainly part of this as well. And mechanical factors like macro trauma, micro trauma, overload or overstretch can injure a cell. And then, as we also mentioned, nutritional factors. And then we kind of also want to couple that with just cellular aging. And as cells get older, right, cells are sort of like a microcosm of the whole person. As people are getting older into their 70s and 80s and 90s, they're often not doing as well, and neither are their cells, okay? So their cells might start to become degraded, to have suffer from the effects of aging. Okay, and any of those things can kind of begin an inflammatory process. And once there's a trigger for it on that cellular level, then there's going to be a vascular response. So white blood cells and macrophages are going to arrive on the scene, okay? They're getting signals from the injured cells to go there. They're literally drawn to that area, okay? So there's a migration of inflammatory cells to the site of the injury, and there's also a release of plasma proteins, right? Through the vessel walls, plasma proteins go kind of from the blood out into the tissues. And those things, both the plasma proteins that have now been sort of released through the vessel walls into the tissue, and the white blood cells and the mast cells, those inflammatory cells that have now arrived on the scene, what they do is they release pro-inflammatory mediators. Okay? Those are things that you've heard of, like histamine, that comes from mast cells, prostaglandins, leukotrienes, and cytokines, such as IL-1 and TNF, right? Tumor necrosis factor. These are basically chemicals or signalers that these cells or the plasma proteins release that sort of drive this inflammatory process. Some of these chemicals can irritate nerve endings and be directly related to pain. Okay? They might cause more vasodilation and be related to the swelling. There are also going to be release of clotting factors, because your body knows if there was some sort of trauma or damage to tissue and it's bleeding, your body automatically knows, I think we should do something to try to stop this bleeding. So some of the cells will release clotting factors to try to stop the bleeding. Does that make sense? Okay. Nerves in the area as well will have changes in their expression of neurotransmitters. So the actual nerves themselves and the neurotransmitters going across synapses can have altered levels, such as altered levels of serotonin. Okay, and then finally, all of that vascular response leads to the exudation of fluid, or exudate is the term for that fluid that sort of is leaching, kind of going across the blood vessel barriers into the tissue, and that's the cause of swelling. Okay, so exudate and swelling are somewhat synonymous terms. Okay, so that's kind of it in black and white, right? In 24-point font. But here it is in a picture. So we have some sort of injury to cells. Okay. Blood vessels in the area are going to dilate. Certain cells are going to migrate through mast cells, macrophages, and they're going to release these certain chemicals like IL-1, 6, or 8, TNF-alpha. There are different cytokines, leukotrienes, plasma proteins coming out, and they're all releasing these chemicals, right, that are associated with swelling, with pain, with irritation of nerve endings. And eventually, in a normal situation, something will happen. Eventually, those signalers will get turned off. Because as these cells, yes, they release cytokines, pro-inflammatory cytokines, but they're also programmed to start to release anti-inflammatory cytokines that will, in a normal situation, will eventually turn the inflammation process off, right? So in a normal situation, the inflammation process starts to kickstart the healing process, but then the body knows through other chemokines and cytokines to make it stop, right? Stop the madness, and because the problem has healed. So in a normal situation, once the person is healed, the inflammation is gone, right? But sometimes it doesn't go away completely. There are, as we mentioned earlier, chronic inflammation. So let's say the person kept stressing the tissue, kept doing the same irritating job or sport or whatever it is. They kept micro-tearing the tissue, and they kind of developed this persistent or chronic inflammation. So it doesn't always shut off completely. In this picture, it sort of illustrates what would happen in a very normal situation. After the repair process, all the inflammation has done its job and it stops. But sometimes it can linger, or it could reoccur, or it can become chronic. So why does it happen? So we know sort of what triggers it. We sort of talked about what's going on in the cellular response, vascular response. But why? Like why, even from the get-go, does this happen? Well, one is it's going to defend against pathogens. So if you've got an infection, you need inflammation because it's the white blood cells that will fight the bacteria or the fungus spores or whatever it is, right? Those white blood cells are your body's way of getting rid of the infection or getting rid of the antigens. So it acts as a defense against pathogens, and it will also kickstart the healing process, as we just saw in that prior slide. If you've got sort of some sort of cellular injury or tissue damage, this inflammation sort of starts the healing process, okay? You're gonna learn much more about that on October 18th. So in this very same class, we'll have a whole lecture really dedicated toward tissue healing and wound healing. Okay, so we're gonna kind of dive a little bit deeper into that in a few weeks. The other thing that inflammation does is it helps remove debris or damaged tissue. So if there's anything in there that shouldn't be there, for example, necrotic or dead cells, the body can make them go away. It can kind of eat them, right? That's phagocytosis. So it kind of cleans up the area, removes things that shouldn't be there, removes dead or damaged tissue. Okay? So it sounds like, well, those are good things, right? We definitely want defense against germs. If we damage or injure a tissue, we want to kickstart the healing process. And if there's bad stuff in there, like necrotic tissue, we would ideally like our body to do something to try to make that go away. So all those things sound good. So why does inflammation get a bad rap? And why do we take anti-inflammatory drugs? Discuss. I'll wait for somebody to offer. There's a number of different reasons, so anybody want to take a stab at one of them? Go ahead.
Well, as we had said, the inflammation can cause pain, so that's the person's not going to be happy about hurting, or if they're swelling, they're not able to move, and if they have a job that they need to move for, they're going to be frustrated.
Right. So inflammation causes pain and swelling and loss of function, and people don't like that, right? So if you take anti-inflammatories to sort of dampen this inflammatory process, you will hopefully have less pain and improved function, and you'll be, therefore, more satisfied and happier. Go ahead.
It's probably not good to take like in the acute phase, so that if chronic inflammation starts moving, it could help settle that down.
Right. So maybe, right, if we think of inflammation being normal, the fact that in an acute phase we need it, but if there's too much of it, or it lingers chronically, then that's when we would want to do something about it. Because one thing that generally happens with the body with inflammation is there's more of it than we need, or it's taking longer to go away than we'd like, or it's becoming a chronic problem. And in those cases, it's sort of no longer serving its purposes, it's only causing problems. Right? So in those cases, we might want to take anti-inflammatories to resolve or lessen chronic inflammation, to help dampen inflammation when there's just so much inflammation that it's causing a lot of pain or muscle spasm or limitation. All right? Yeah. So it's sort of like, I guess the truth is both. Inflammation is bad, like we talked about on that earlier slide, linked to all those diseases, right? But inflammation is also good But it all depends on the context in which we're talking about it, right? If it's right after an acute injury, or if we have an infection, we need some inflammation. We need inflammation to do these things. But if there's too much of it, if it's lasting for too long, or it's becoming chronic, then we have a problem. Okay, so we're going to talk now about some specific infectious disorders of the musculoskeletal system, because we know one thing that causes inflammation is infection. Dave, go ahead.
I'm just wondering if there's chronic inflammation in a few joints, but it's not osteoarthritis, would that cause systemic inflammation? Or
If there's chronic inflammation where?
in a few joints,
Well,
like for someone who's like 23.
so if there are different, your joints can hurt for different reasons. One could be arthritis, but there are also systemic inflammatory disorders that are associated with joint pain. So yes, inflammation can make multiple joints hurt. And you know, it can be sort of a vicious cycle too. Being in pain and being distressed about pain and having pain can make you feel kind of unhappy and somewhat depressed. And being depressed makes chronic inflammation or systemic inflammation worse. So again, it's kind of that idea it could be a vicious kind of cycle. Okay. So let's talk about osteo, which means bone, right? Myelitis, and that means an infection in the bone. Okay? Osteomyelitis is an infection within a bone. And one form is acute hematogenous osteomyelitis. So acute meaning relatively recent onset, right? Sort of a sudden problem. Hemato, blood. Genius means kind of like where it came from. So it came from the blood stream. Somehow some bacteria or something bad in the bloodstream got into the bone and caused an infection of the bone. All right? This is usually seen more in children, usually more in males than in females, and it primarily affects the growing metabolically active regions of the bone, so more likely to occur in the ends of bones, right, where you have the growth plates, where you have the articular cartilage causing growth of the ends of the bones. That's where there's a lot of metabolic activity in a growing child, right? Because how is the bone growing in length? From the growth plates and from the articular cartilage. Where are those things located? Towards the ends of the bones. And where bone is more metabolically active, it's a little bit more vulnerable to a blood-borne pathogen. Because when it's more metabolically active, there's more blood flowing to it. There's things kind of going on. In this process of growing, it needs blood supply, and there's a lot of metabolic activity. So it's sort of like a sitting duck for an invasive bacteria species that could kind of cause an infection in the product. And we do see this more in children than in adults, but it can certainly happen in adults as well. It's usually bacterial. It could come from abrasions of the skin where bacteria gets in, popping a pimple, an upper respiratory infection where the bacteria becomes bloodborne, or another risk factor if there's local trauma to the bone, where the bone is maybe already reactive with like a little inflammation and therefore additional blood flowing to it to begin with. Now if you've got some bacteria in that blood, that increases the vulnerability. Now, when you've got an infection in a bone, remember, what is infection? Its pressure is going to increase, swelling is going to increase, vasodilation. Well, in bone, that is a big problem because there's nowhere for it to go, really, right? Bone can't expand like a balloon, right? Like if you have an infection in a muscle, it might really like balloon out, right? Because there's a lot of connective tissue. The swelling can expand. In bone, there's very little expansion capability of bone. So what's going to happen instead is the pressure is going to start to escalate very dramatically and very quickly in the bone, causing severe pain, right? There might be, if that fluid and that infectious material and pressure continues to build up, there might be development of a subperiosteal abscess. And there might be necrosis. So here we have osteomyelitis in the distal femur. We can see there's some bone death, right? Like a darkened area where the bone has died. So there's some necrosis there. And down here we can also see, looks like something's kind of pushing out beyond the periosteum, right? So if there's this fluid and this pressure building up in the bone and the hard bone tissue can't really expand, what it can push out against the periosteum and push out the periosteal wall and sometimes break through the periosteal wall. Because the periosteal wall can expand or give or get pushed out away from the bone, right? And that's a subperiosteal abscess. Okay. So let's, the clickers are not working yet, so let's just do a little show of hands here. Osteomyelitis can actually be caused not only by bacteria, but it can be caused by fungus or parasites or viruses. Okay. The most common causal agent of acute osteomyelitis is which one of these? Staphylococcus aureus, which is a bacteria, yeast, which is a fungus, herpes simplex 1, which is a virus, or Lamania donovani, which is a protozoan, actually like a little critter, okay? So those are 4 different things. One of them is a bacteria, one of them is a fungus, one of them is a virus, one of them is a protozoan. And technically, any of them could get into bone and cause an osteomyelitis. Which of those do you think is the most common, though? So we'll do this by a show of hands vote. Raise, and we'll start in, we'll go reverse order. So raise your hand if you think it's Lamania donovani protozoan. Raise your hand if you think it's herpes simplex 1. Raise your hand if you think it's yeast. And raise your hand if you think it's staph. And that is actually the correct answer. So, bacterial infections are the leading cause of osteomyelitis. Can be caused by any of those other things on the list. So they're not, to imply that those things don't cause osteomyelitis. They can, but bacteria, number 1. Numero uno, okay? All right. So much for that. Maybe we'll get that fixed after the break, maybe not. So, there will be swelling that will push the periosteal membrane out away from the bone. The bone itself can swell. The bone itself can swell a little bit, but remember, not too much because bone is pretty hard and stiff, right? But in someone with osteomyelitis, you will actually see what appears to be increased circumference or swelling in the area where there is an osteomyelitis. So in this picture, the lower of the 2 legs, sorry about the graininess of that picture, is obviously, this is the limb of the 2 limbs that has osteomyelitis. Okay. All right, very good. Let's go on to the next slide. Lucas, did you do that? That wasn't you, seriously? Because that red thing was standing up, right? And now it just fell over for no apparent reason. But that's kind of weird. All right, I don't know. Well, before we take the break, though, I do just have to warn you guys, sometimes this time of year, weird things do start to happen a little bit in the classroom because it is October and this is the month where, Halloween is in October and it's just a crazy time of year. I don't know what could have explained that. Really. Tolu, was that you? Did you do something? Did you do? You did? It was you? Oh, okay. All right. So we don't have to worry. Okay, maybe. All right. Unless Tolu's just saying that to make us not worry. Well, let's not worry for now. Let's just hope that nothing weird happens. We'll come back to this slide after the break because maybe I'll have the clickers working then. But let's do one more slide and then we'll take a break. Okay. Acute hematogenous osteomyelitis. The signs and symptoms. 50% of the time, there was some local trauma to the area, severe constant pain, tenderness, malaise, and fever. So the malaise is that just sort of general sense of not feeling well, kind of feeling crappy, achy, tired, weak, not good. That's malaise, right? Fever, and soft tissue swelling on the surface. So those are the things that we're going to see clinically with an osteomyelitis. This is the person's limb, where we can see swelling. We can actually see it looks like there's perhaps a hole in their skin here. We'll talk about that in a second, why that might be there. But if we looked at the X-ray of the bone, we see necrosis, and we see actual damage to the bone from that infection. Now the interventions here, there's not a whole lot that we're going to be doing as a physical therapist. This person needs to see their doctor, okay? They need to be put on antibiotics, very aggressive antibiotics, often IV antibiotics, sometimes even with a short hospital stay for IV antibiotics. They need rest, they need analgesics to help relieve the pain. And I'm just going to put this back up because that's supposed to be up. I don't know why it fell over. We'll have it back up. Okay. And surgical decompression, right? Meaning they might need to go in surgically and remove dead bone. Okay. The complications are bone destruction, septicemia, pathological fracture of the bone, joint contractures, if it's near a joint, and it usually is, because remember, it usually happens near the ends of bones. Overgrowth or cessation of bone growth. If it's in a growing child, the epiphyseal plate might prematurely ossify or close, and that could cause problems with bone growth. There could be a cessation of growth, or the epiphyseal plate might kind of overreact and grow too much. And finally, death. And by here, we don't mean death of the bone, we mean death of the person. Okay? And that is usually related or linked to septicemia. Because what septicemia is when that infectious agent, right, like the bacteria, starts circulating throughout the body and infecting not only that small pocket or region of bone, but really multiple organ systems will start to shut down, and there'll be this immune system reaction that is associated with septicemia. Okay, all right, very good. All right, I think we might have another one about Tolu. All right, now I was watching that time and I didn't see you do anything. So I don't know, forget it. We're not even gonna talk about it. We're just gonna roll it out of the way. We'll just pretend it never happened. Okay, now we still have a few more slides to talk about acute hematogenous osteomyelitis. So we'll jump back into that a little bit more after the break. So let's take a break for about 10 minutes. I'll see you soon. Now, so let's see how you guys do with this one. Who is at the lowest risk the lowest risk of developing osteomyelitis? A child, a middle-aged healthy adult, a middle-aged healthy adult with a compromised immune system, an adult IV drug user, or an older adult with alcoholism. So of those 5 options, who is at the lowest risk for developing an osteomyelitis? Oh, sorry. That's because I have to remember to relaunch the poll for each one of these. Okay, try again. It'll work now. Okay. Okay, so who's at the lowest risk for developing osteomyelitis? Remember, just hold that button down for a while. Hold the button down. Point it up toward the front of the room. That should do the trick. Don't stress if you fear that your answer might not be coming in. You're not going to over-stress about that. Okay, let's see how you did. We want to see the results, please.
It's been all day tonight.
Okay. So neither of yours are working? Yours are, but yours does? Okay, so you can vote together, share. Neither of yours works? Both of yours work? So you guys are going to vote together and share. Discuss.
It'll say like A or whatever.
There's nothing wrong with avocado.
And not all the votes registered, so you might be wrong. Okay. All right, guys. Let's talk about this one, and also let's not stress too much about. In the future, we're going to probably not even be using the clickers anymore. The clickers are sort of a dying art here, but we also haven't quite figured out what other platform we like best yet. So we're sort of playing around with Poll Anywhere and Kahoot and all these things. So let's, at least if one of you sitting at the table, one in your pair, has a functioning clicker, you can discuss and cast a single vote together, okay? If you can come to a consensus. All right. Yeah, there might be some arguments, but that's okay. Middle-aged healthy adult, 89% of you getting this right. A child is at the greatest, generally, that's who most people who get osteomyelitis are children, because their bones are more metabolically active, right? And these other 3 things, someone with a compromised immune system, more vulnerable to infection, an adult IV drug user, obviously multiple opportunities there for bloodborne infections, and an older adult with alcoholism that also compromises the individual's immune system, so they might not be able to fight off infections as well. So the person least likely to develop an osteomyelitis is the middle-aged healthy adult. Okay, we did that. Oh, this is where we left off. The root of infection, acute hematogenous osteomyelitis. Are there any notes on this slide? No. Okay. So here this little dot right here, all right? There is an osteomyelitis inside the bone, all right? Pressure's building up, pain, right? The pressure is increasing. It's starting to push away against the periosteum, okay? It might break through the periosteum. It might then break through the skin and start draining out the skin, because that fluid's got to go somewhere, okay? And the bone's only going to give so much. And that's why the pain with osteomyelitis is so severe, right? Because that pressure's building up in the bone, and the bone just can't expand to accommodate it very well. This shows an acute hematogenous osteomyelitis in a child within the hip joint. Okay, so now here's the little spot of osteomyelitis, right? It's in the metaphyseal region of the bone, and it's going to sort of push out. If it breaks through the periosteum, where is it suddenly going to be? Inside the joint, right? So in this case, not only in this child, not only do they have an osteomyelitis, now they might end up with an infected hip joint. Because if it does leak out and it's intracapsular, it could then get into the joint, right? The bacteria can get into the synovial fluid within the joint. Now, if that osteomyelitis was down here and it broke through the periosteum, well, we're outside the joint capsule now. So it's still a big problem. It might now break through the skin and create a draining sinus that leaks out nasty pus and smelly things out through a hole in your skin, but at least it's not going to be draining into the joint. So this is now a double problem. We have an osteomyelitis, and we might also have an infected hip joint.
I have a question.
Yeah.
Is it better that it's contained, or is it better that it's contained?
Oh no, because it's now you just have two problems instead of one, right? And here, if it's not involving the joint, you have an osteomyelitis, and that needs to be treated. If you have an osteomyelitis and now an infected joint, that bacteria and that infectious exudate within the fluid of the joint might erode the cartilage, it might damage the cartilage, it could cause further inflammation of the synovial membrane, so it's like double trouble. Yeah.
Is that when you start to see like systemic problems? Like how you saw when people have that
Well, so with an acute hematogenous, you know that the bacteria got there through the bloodstream to begin with. So whether it becomes a truly septicemia or a systemic infection kind of depends on what the rest of your body is doing elsewhere to sort of deal with the bacteria or whatever it is. If it's not winning that fight, then it's going to start circulating around and become systemic. And this just, I'm going to turn the lights up so you can see a little bit more clearly. This is just sort of showing in someone with acute to chronic, so someone who had an osteomyelitis and they weren't successfully treated, right? And that's why this picture is actually so old and kind of grainy, because today most people would be successfully treated with antibiotics. It would never get this bad. But what bone is involved here? Well, it's primarily the ulna. And we can see early on acutely, right? You know, there's a little increased activity here going on, the bone's lighting up a little bit more. And then you can see over time, there's destruction of bone, there's expansion of the periosteum. It looks like maybe leaking of fluid out of the periosteum. The bone is becoming increasingly disfigured, right? With areas that have reduced dense bone density, widening. Later, the bone actually now becomes thinner because parts of it are actually just flat out dying, right? And ultimately, this person is left with a very disfigured, dysfunctional ulna because of the destructive processes that in this individual were unchecked by antibiotics. Okay. So this is a draining sinus, and you're not going to, in someone with an acute hematogenous osteomyelitis, you won't see this, because hopefully the infectious disease doctor or the emergency room doctor, they identify it in time, the person goes on antibiotics, and it never gets this bad. But if it's untreated with antibiotics, remember what's going to happen? Well, the bone's only going to give so much, so it's going to start to push out against the periosteum. It's going to bust through the periosteum, and then it's usually going to eventually make a hole in the skin, and the person's going to start to have an open draining sinus, which is literally like a hole in the skin out of which is draining nasty infectious fluid. Okay? Now, this occurs when an acute osteomyelitis goes untreated. You might sometimes see this draining sinus, severe pain and swelling and tenderness. And this is not just the draining sinus that has gotten bigger, this is post-surgical. Now, because what they had to do is they had to go in and actually scrape away and remove all of the infected tissue, including the infected bone. okay? The treatments are bed rest, antibiotics, surgical incision and drainage. So this is status post, surgical excision, and letting it sort of drain. All right. Complications are the chronic draining sinus, contractures, pathological fractures, septicemia that could lead to death, malignant changes in the epidermis, which is the skin, obviously. Yep.
Sorry.
No. It might go untreated because, you know, you're living in a region of the world without access to healthcare, or you ignore it. You know, or you're like, you know, you're living like in the hills of Appalachia, or you're homeless, or you don't have health insurance. Those are pretty much the reasons why. Because it's going to hurt. But some people just ignore it. Yeah. Or can't access healthcare.
I'm just wondering, if someone has arthritis and they have a bacteria infection, is it possible if the bacteria infection isn't cleared from the system, like for the arthritis, to get some of the bacteria because the bone is damaged, so there's an opening? Is that possible?
So if someone has arthritis, could they end up with an infection in the joint just as a result of the fact that they have arthritis?
Yeah.
No, usually not.
Okay.
Usually, other types of arthritis won't increase the risk of an infection getting into the joint.
Okay.
Right? But an infection in the joint can cause infectious arthritis. Parker.
So I just, back to your previous point, wanted to state that I live in the Appalachian Mountains.
Uh-huh.
So
Uh-huh.
you were talking about the hills of Appalachia. That's a good place.
Uh-huh.
It's not
No, okay. So sorry about that.
I'm not offended. I'm just
Right. Okay. But, okay, yes. So they're very lovely, in fact, yes, they're very lovely parts of the Appalachian Mountains. I've been there myself, actually, very beautiful. But there are also, like many other parts of the United States, and I didn't really mean to pick on Appalachia, but for example, Camden, New Jersey, right? Kensington area section of Philadelphia. So there are pockets of poverty, and there are certainly, there are pockets of poverty in some mountainous regions as well as city regions. So, sorry, nothing against Appalachia. Okay. Thanks for calling me out on that. No, it's serious. Really, seriously. I'm glad you mentioned that. Try to make a mental note not to use that same reference. Ever again. Okay. Okay. So this is a grainy black and white image of someone someone's arm with the draining sinus, but then on a film with you can actually see what happens is here's the osteomyelitis pushed through the periosteum and the fluid draining out into the tissue, probably out through a sinus in the skin as well. Okay, so if someone has osteomyelitis, what's the goal of antibiotic treatment? Well, to eventually get the patient to be pain-free and full weight bearing. Okay. It's a situation that is hopefully identified very early and treated very aggressively with antibiotics. And then the chances of, minimum long-term sequelae are much better. This is someone who probably had a situation that wasn't caught early enough. You can see sort of residual thickening and changes in the dermis and the skin. This person probably had a more severe osteomyelitis that maybe became chronic, maybe needed some surgical excision. It still can be treated. It's just a lot harder. It's a lot harder to fight the infection when the infection has spread and festered within the bone and started to cause draining sinuses. You need surgery, you need months and months of antibiotics in those cases. So it's going to be more challenging to treat. Okay, let me reset. Yep, pulling open. Mary had a THA total hip arthroplasty, and then she had that in 1980, and then 26 years later, she had a revision. The revision became infected. Go ahead.
I just had a question. Is osteomyelitis typically found in the lower extremity, or is that, it just seems like most of the pictures are...
So yes, and let me come back to it. Like, let me do this and we'll jump right back on that. So Mary, the revision became infected. She may experience what? Hip pain, fever, swelling, prosthetic loosening, or any of the above. So her hip, which is now a prosthesis for the second time, the area is infected. What's she going to have? And let's see how you did. Here we go. We need our answers. Where are the answers? Very good. Any of the above. So if you got thrown off by hip pain by the fact that she doesn't have her own original biological hip and it's a prosthetic hip, I didn't mean to throw anybody off by that. It's in the region of her hip. So even in someone that has a total hip arthroplasty, even if it's a prosthesis, we still sort of refer to it as the hip. Okay? All right. So she could certainly have any of those things. Very good. Now, question was, is osteomyelitis more common in the lower extremities? Is that the question? And the answer is yes. It can happen in the upper extremities. It can even happen in the spine. But it is more common in the lower extremities. And the reason, because remember, it's more common in children, more common because the bones are more metabolically active. And it's also linked to bone that has been recently traumatized in some way, like a blunt injury or some sort of impact. And the lower extremities are more vulnerable to that, right? Falls on the playground, right? Getting kicked by someone while you're playing soccer. So it's just that legs are more likely to be kind of injured and exposed, or your knees are more likely to be scraped than your elbows. Okay? All right. Very good. And I think we have next, yep, we have enough. Now I have to just click on one little thing up here. Give me a second. Give it a second. Okay. Spinal infection involving an intervertebral disc or vertebral end plates has a name. All right. Now, I know we haven't covered this. In case you're wondering, I have no idea what the answer to this is. It's because I haven't told you in the past. If you read ahead in the readings, you might know, or if you might recall from prior knowledge. So when you have an infection that is in the intervertebral disc, right, in the disc between two vertebral bodies, or the vertebral end plates, that has a name. And what is that called? Is it stenosis, herniation, myositis ossificans, discitis, osteosarcoma, or degenerative disc disease? So even if you don't know the answer, try maybe through process of elimination to narrow it down and take your best guess. Okay. Let's call the question, see how you guys did. You might have to, this is acting a little persnickety still. We're not seeing the answer. I want to make sure you can see that, so we're going to come back to it. Yep. And 42% of you got it right. It is actually discitis. All right? That's when the infection gets into the intervertebral discs. All right. Other infectious disorders. Acute septic arthritis. This is when you have bacteria or something else, it could be a fungus, a virus, a protozoan, but it's in the synovial joint. This also is more likely to happen in children. And as we saw in that graphic earlier of the hip, it's often associated with a hematogenous osteomyelitis if the metaphysis where the osteomyelitis is intracapsular. If that's still within the joint, then the infection might get out into the joint. There's going to be purulent exudate, and so that's why this is like a double problem. And even though it's now contained within the joint, you have purulent exudate within the joint fluid that's going to cause pannus formation, synovial membrane. It's going to react. It might start to stick to cartilage. Cartilage might start to die. Literally, it could destroy the joint. The signs and symptoms are joint effusion, severe pain with weight bearing on movement, spasm, and tenderness. This is a 19-year-old wrestler with septic arthritis. And there's also, you can't really see too much happening on the x-ray, except for the fact that his shoulder joint is not properly aligned, right? Here's his glenoid fossa, right? Where's his humeral head? Like way too far down, okay? So he has an inferior subluxation of the humeral head for some strange reason. Why? Because within the joint, there's an infection, and all that fluid has pushed his humeral head down, and it's caused a subluxation of the joint. And you can see on the MRIs all of this excessive fluid and pressure building up in the joint. Now, what is the medical intervention for that? Well, obviously, antibiotics, of course. That's a no-brainer. But how can the surgeon get rid of that extra fluid? They could take a needle and do the opposite of an injection. And the opposite of an injection is a needle aspiration. That's when you take an empty needle, you put it in, and then you slowly pull the plunger to suck fluid out. Okay? So you could do a needle aspiration, arthroscopy, lysis and lavage, where they just go in, through little holes and they sort of get rid of some stuff that shouldn't be there. And this person might need to be immobilized in a shoulder sling for a while as well, for just some protection. All right, osteomyelitis and septic arthritis secondary to wounds. So this is just a different path. Like the problem is essentially still the same problem of osteomyelitis. But sometimes the bacteria gets in like a more direct path. In other words, rather than traveling through your bloodstream and eventually getting to that bone because that bone is metabolically active and it's got a lot of blood flow and the bacteria was in the blood and just landed there, here it's sort of like gets right to the bone through a puncture wound, an open fracture, a trauma that broke the skin, or non-sterile surgical techniques. Okay. So just as a little preview of the Mutter Museum next week, surgical techniques, right, were not even thought about or used, let alone used, until the 1860s. And it was Dr. Lister who wrote the first article on antiseptic technique. It was the beginning of the germ theory of disease. But before the 1860s, surgeons had no idea this concept of the germ theory of disease. They didn't wash their hands between patients. They didn't wear gloves. They would take maybe their scalpel or their instruments and they just wipe them off on a towel, and then they'd work on the next patient. So what do you think happened to a lot of people that had surgery before the 1860s as a result of that? They died, more than 50%, right? The mortality rate for surgery in the era before antiseptic technique, which is basically anything before the 1860s, the mortality rate for having any sort of surgery was more than 50%. It was like flip the coin, right? You might die if you have surgery. 50-50, not even, it was worse than 50%. Okay, so good thing we don't have to worry about that today, because hopefully if you have surgery, you won't get an infection, it does still sometimes happen, but at least the surgeons are doing everything they can to create a sterile operating field and prevent infection. Now, if someone obviously has an open wound or an open fracture, there's got to be careful wound cleansing and debridement and drainage and antibiotics. Now, osteomyelitis can sometimes get into the vertebrae. Now, we said when it's involving the disc, we had that clicker slide. If it's in the disc itself, we call it discitis. But sometimes it's not just the disc. Sometimes it's the actual spine, the vertebrae, the vertebral bodies, right? The bone of the spine. Severe back pain, right? Tenderness, spasm, progressive bone destruction and deformity. Okay. A common germ is the tuberculosis bacteria, right? Tuberculosis normally affects the lungs, right? But what's right behind the lungs? Your thoracic vertebrae, right? So if the tuberculosis gets into the vertebrae, it's called Pott's disease. It's a tuberculosis osteomyelitis of the spine. And if it's not treated, you can see severe spinal deformities due to the destruction of the bone, possibly paraplegia, right? Spinal cord damage, or called equina damage. It can be very, very problematic. And you'll see in the Neuter Museum, in one of the cabinets, there are some actual spines of children that had severe Pott's disease before the days of antibiotics. Now today, if this is identified early, it can be successfully treated with antibiotics. We take antibiotics for granted when we have an infection. Guess when did antibiotics come into widespread use? Anybody want to take a guess? Right, World War II, like late 1940s, early 1950s. So less than 100 years ago. Before that, if you got an infection like this, it would just spread and you were on your own. You would hope that maybe your body's own immune system, in some cases your own white blood cells, could combat an infection successfully. But sometimes it's going to fester and it's going to spread. And in this case, and this is why in the Neuter Museum, where a lot of the specimens are from the early 19th century, you'll see, and I'll point them out to you so that you don't miss them, you'll see some spines from children that had Pott's disease. And you'll see the severe angular deformities that resulted. Okay. So this is and why is this picture so old? Because today it's much harder to find children that have Pott's disease, right? Because they can be treated with antibiotics. But in this case, there was destruction of the upper lumbar vertebrae that resulted in this very strange kyphotic hump here in the upper lumbar region due to destruction of the vertebral bodies and deformity that resulted. Okay, tuberculosis, that same bacteria that we usually associate with the lungs and the respiratory system, can also get into joints. And obviously, if you have just like any other infection in a joint, in this case, if it's due to tuberculosis, you're still going to have pain with weight bearing, pain with range of motion, pain with swelling. The infection within the joint can trigger the pannus formation. Again, that's when the synovial membrane starts to grow a little extra and stick to the cartilage, and that's not good. It deprives the cartilage of synovial fluid. The cartilage might start to die. Synovial membrane hypertrophy, effusion, cartilage necrosis. What's the treatment? Antibiotics, rest, ice, elevation, and a synovectomy, which is surgery to go in and remove excessive amounts of synovial membrane that may have formed. Okay. Next, we want to talk about non-specific inflammatory disorders of joints. One of the first one that comes to mind usually is rheumatic disease. Right? Rheumatic diseases are diseases that are attributed to pain and stiffness in musculoskeletal tissues like rheumatoid arthritis. There are various forms of rheumatic diseases, rheumatoid arthritis being one of them. Okay. Rheumatoid arthritis is an inflammatory polyarthritis, meaning that it involves multiple joints. In a person that has rheumatoid arthritis, they tend to have cycles of exacerbation and remission. The more cycles they have, the more likely they're going to have prolonged deformity because of the progressive damage to the joint. That progressive damage to the joint can affect the alignment of the joint and the movement and the function of the joint. So you see this person's hand drawing, someone with rheumatoid arthritis. They have had multiple exacerbations, obviously, because they have a boutonniere deformity of their thumb, ulnar deviation of their metacarpal carpophalangeal joints, swan neck deformities of their fingers. We'll go over those in a little bit more detail in MSPT1 in the spring when we cover the hand unit. Rheumatoid arthritis occurs in about 1.5% of adults. Happens in females more than males. Usually the onset is in the early adult years between 20 and 40. It typically involves the distal joints first, and it's usually symmetrical, meaning both obviously the left and the right, and we still really don't know the cause. There's some speculation that there might be a viral trigger, so exposure to a virus in the environment might be something that triggers this. We know whether or not there is a virus associated with this, there's certainly an exaggerated immune response. It's like, and I kind of think of a lot of these sort of autoimmune diseases as like your body becoming allergic to yourself and your immune system making mistakes. Because normally, your immune system's only going to get revved up when you've got a bacteria or a virus or a germ, right? But sometimes your immune system might get revved up by mistake, right? Autoimmune. For no apparent reason, your immune system causes inflammation and starts to attack your own tissues. And that's kind of what is going on with rheumatoid arthritis and several others that we'll talk about. So we're going to see with rheumatoid arthritis inflammation of the synovial membrane, again, pannus formation, joint destruction, and it's associated with this autoimmune response. We see effusion, periarticular swelling. And so what's the difference between those two things? When we hear the term effusion, that's limited to the joint, like the area of the joint capsule. So effusion, think a joint. Periarticular means around the joint. So proximal to the joint, distal to the joint, also swelling in the neighboring areas, okay? Contractures and adhesions within the joint. Sometimes we see contractures or adhesions. Sometimes, and really not on the slide here, sometimes we might see the opposite of that. We might see subluxations or even dislocations of joints, okay? Fatigue, pain, stiffness, ruptured tendons. People with rheumatoid arthritis, they have pain and stiffness that's usually worse in the morning when they get up. And as the day goes on and they're moving around, they'll usually feel like they're loosening up a little bit, right? And why is that? Well, because over the course of the night while they've been sleeping, they haven't been moving much, and that fluid has started to just sort of build up and accumulate. So when they get up, now there's greater pressure within the joints because of that fluid that is built up overnight, and they really feel very stiff. As they start to move around, right? Remember, motion is lotion, right? So our joints will sort of maybe get rid of a little bit of that excess fluid, and you'll start to feel a little bit looser and move around more freely. Okay. This graphic shows the inflamed synovium in someone with a flare-up of rheumatoid arthritis. The outer fibrous capsule is also going to be inflamed. And then you see the pannus formation. And by pannus formation, that's where we mean the hypertrophied synovial membrane. It sort of juts in and it starts to stick to the cartilage. Okay? and it can cause cartilage necrosis and damage, and subsequent destruction of the alignment and the function of the joint. Okay? So a little bit about rheumatoid arthritis. In your homework, you will look up some of the drugs that are used to treat rheumatoid arthritis. That's what this week's homework is about. So let me reboot this slide. Jeanette's lab values show a low white blood cell count, high viscosity in synovial fluid. Her erythrocyte sedimentation rate is mildly increased, and she has a negative rheumatoid factor. Now, I know this one's a little bit of a stretch, so you're gonna have to do some process of elimination or thinking here. Those are the findings from her labs. Her white blood cell count is low, high viscosity in the synovial fluid, ESR mildly increased, a negative rheumatoid factor. Is that more like rheumatoid arthritis findings or more like a DJD findings? And if you not really have any idea whatsoever, just take a guess. Okay, let's sort of see how you did. I'm not expecting a really strong response rate on this one, but we'll see how you did. Oops. Where are the responses? Not showing up. Here we go. Oh, 73% of you got it right. Yeah. So these are actually lab findings that are associated with osteoarthritis, not rheumatoid arthritis. Okay. All right. Now, in someone with, go ahead, David.
Sorry, it's for the last slide. What's a negative rheumatoid factor?
A
What is that?
rheumatoid factor.
Yeah.
So that is a protein, and if you either have it or you don't. Like if it's expressed, you have a certain gene in your cell's DNA that either makes it or it doesn't. So it's like a chemical factor in your blood.
Okay. Thank you.
So the typical RA lab values, because Jeanette, those were typical values for OA, osteoarthritis, but for rheumatoid arthritis, what we see is high white blood cells and lower viscosity in the fluid, ESR markedly increased, and usually a positive rheumatoid factor. And you're also going to, and another thing you'll see in rheumatoid arthritis is C-reactive protein, and that's a protein that is associated with systemic inflammation. Now, C-reactive protein, and even for that matter, positive rheumatoid factor, you will also sometimes see in other diseases or conditions, particularly C-reactive protein. It's not specific to rheumatoid arthritis. It's just, but if you have rheumatoid arthritis, right? Remember, rheumatoid arthritis is an inflammatory disease. So this protein that pops up in greater proportions when you have systemic inflammation or an inflammatory problem, you're going to see more of it. Okay. Extra-articular manifestations of rheumatoid arthritis. There is a box in the book, Goodman and Fuller, the pathology textbook, that I just want to refer you to. But here are a few things in people that have arthritis. Because so far we've been just talking about the joints, right? And how arthritis affects the joints. But often people have compression neuropathies. Why? Because in some cases nerves are passing either through fibroosseous tunnels, like the carpal tunnel, near the wrist joint. So guess what happens if the wrist joint is deformed or inflamed or swollen? It would increase pressure on the nerve. In some cases, nerves pass alongside joints, near joints, right? And if that joint is inflamed or there's increased pressure in the joint, you can end up with a compression neuropathy. Sometimes people with rheumatoid arthritis also have pericarditis, inflammation of the sac surrounding their heart. There could be sclerotic changes in tissues, skin tissue and bone tissue, meaning sort of excessive density of growth. There could be pulmonary effusion, right? As a result of that, there is kind of a little bit of a zeitgeist underway right now to actually not call this rheumatoid arthritis anymore, because rheumatoid arthritis sort of implies that, well, it's a disease of the joints and the only problems that you have are the joints. But it's not. It's really a systemic disease, can also cause these things. So rheumatoid autoimmune disease might be a better name than rheumatoid arthritis because of its systemic effects. Okay, so this is someone with, again, apologize for the graininess, but you see severe joint deformities. People, this gentleman appears to have elbow flexion contractures, wrist flexion contractures, a mild hip flexion contracture, a mild knee flexion contracture, deformities severe at the metatarsal phalangeal joints, as well as noted in the hands, the ulnar drift of the metacarpal phalangeal joints. So numerous deformities. Okay, let me reset our slide, and you can cast your vote in just a moment. Which of the following is not characteristic of acute rheumatoid arthritis? So one of these is not really something that you would typically see with an acute rheumatoid arthritis. 1 to 2 joints involved, morning stiffness, hand joint involvement, rheumatoid nodules, serum rheumatoid factor, or radiographic changes. Which one of those, only one of those things is actually not characteristic, and all the others are. All right. Let's see how you did. Give me just a few seconds to click around as we apparently need to do in order to get the answers to show up. Oh. So, remember, rheumatoid arthritis is polyarticular and symmetrical, so usually there's more than 2 joints involved. So the thing that you usually will not see is only 1 or 2 joints involved with a rheumatoid arthritis. Right? It's usually going to be multiple joints and it's going to be symmetrical. Right? And all these other things, these are things that very likely might be seen. Right? So only A is the one that's not characteristic, and that's because usually rheumatoid arthritis is poly, meaning many, polyarticular. Okay. So, for rheumatoid arthritis, what are the interventions? Well, there are pharmaceutical interventions, and you will be looking those up for your homework. Certain joints might need protective positioning or splinting to help minimize their deformity or help improve their alignment or minimize stress on the joint. Therapeutic exercise, thermal agents, such as, let's talk about it right now, thermal agents. Given that rheumatoid arthritis is an inflammatory disease, sort of based on that alone, what do you think would probably be a more logical choice, heat or ice? Ice sort of sounds like it makes more sense, right? Maybe dampen the inflammation, control the swelling and the warmth, right? Because ice helps dampen, cold and ice does help dampen inflammation. That's why we use it. If you injure a joint, what do? You pack it in ice and you elevate it. What's really interesting and somewhat confusing about people with rheumatoid arthritis is they hate ice, they hate cold, it makes them feel worse. They like warmth and heat. They feel like it helps them move more freely with less pain. So I'm not going to put ice on a patient with rheumatoid arthritis, because most people are just gonna feel aggravated by that and feel worse by that. If they feel a heating pad or some warmth makes them feel better and move more freely, okay, you can go with that. Despite the irony, right? Go ahead.
Would any heat, would too much heat increase the swelling or the?
Yeah, so you have to be kind of careful with it. So let's say if it's rheumatoid arthritis flare up in the feet and in the ankles, and you think, okay, well, the warmth makes the person feel better, I probably would still not want to put them in like a super hot dependent position whirlpool for a half hour, right? Because that might cause greater swelling, even though it might feel nice and they might like the hot water. The dependent position, the prolonged period of time, plus the hot water for that long, might increase the swelling. So it's got to be used cautiously and in moderation. Right. Surgery, synovectomy. If there has been that pannus formation and hypertrophy of the synovial membrane, surgeon can go in and take some of the excess out. Arthroplasties are joint replacements. Tendon repairs, grafts, transfers, if tendons are ruptured or damaged, because remember, a lot of our tendons pass over joints. So if the joint is inflamed and swollen, sometimes the tendons will rupture, or they'll get pushed off to the side, or become damaged in some way. And then finally, arthrodesis is a surgical fusion of a joint. A purposeful surgical fusion of a joint is an arthrodesis. Okay. Might be the last slide on rheumatoid arthritis. Yep. Melissa, was that you? Were you messing with the lights? Because did anybody notice that? Like something weird just happened with the lights. All right, I guess I better explain what might be going on. I was hoping this wasn't it. I was hoping it was just Toru before, but this time of year, sometimes the ghost of Aunt Mary Keytrees starts messing with us. And one of the reasons is, I think one of the triggers is, because she actually had ankylosing spondylitis. So, I mean, maybe the fact that coupled with the fact that Halloween's coming up, I don't know, sometimes, like every once in a while, like weird things happen this time of year. Like you feel a chill in the air, or you start to smell like cigarette smoke when no one's smoking in the room, right? Lights flickering, red bolsters toppling over for no apparent reason. Well, at any rate, Aunt Mary, and maybe she's mad that I'm talking about this condition that she had. Well, she had it. She had ankylosing spondylitis, which is Marie-Strumpel disease. It's an inflammatory disease that causes progressive, gradual bony ankylosis of the spine and the proximal joints. Now, ankylosis means fusion. In this case, it's not done by the surgeon. It's not an arthrodesis. It's because of the disease. The disease, the inflammation, and the fibrosis, and the sclerosis, and the changes around the joints cause the joints to fuse in the spine, okay, as well as in the proximal joints. Now, that's a big problem. It can be minimized if someone does have this. Hopefully they're treated with anti-inflammatory drugs and physical therapy to, one, minimize the inflammatory process, and then physical therapy to try to maintain the joint motion and function. Well, poor Aunt Mary didn't know any of that, right? She just thought her back hurt and her neck hurt, and she ignored it, and she didn't go to the doctor. And what happened over multiple years of her life, she started to become stiffer and less mobile, to the point where she literally had no range of motion in her spine, okay? Now, we didn't really understand as kids, like on the farm, we didn't really quite understand why Aunt Mary kind of walked so funny, and if we were behind her and we yelled hey, Aunt Mary, look back here. We would expect a normal person to do this, right? Well, Aunt Mary couldn't do that. She'd have to be like, "What do you lousy kids want?" Right? she didn't have any range of motion in her spine. So she sort of had to like twist her hips and her knees to turn around. Anyway, yeah, Aunt Mary, she was a little rough around the edges, chain smoker, big teased up orange hair. Well, at any rate, let's go back to ankylosing spondylitis. The onset is typically in the late teens and early 20s. There's a genetic predisposition. Thank goodness Aunt Mary was only my aunt through marriage, like it was her husband who was really genetically related to me. So hopefully I'm not too worried about ankylosing spondylitis on my side of the family. But there might be a genetic predisposition, in some cases totally enigmatic and unknown. If misdiagnosed as mechanical back pain or neck pain, and that was the case with Aunt Mary, there might not be adequate medical management, and the next thing you know, you're going to progressively lose range of motion in your spine. The pathophysiology is gradually the facet joints and the intervertebral joints of the spine become fused, known as bamboo spine, because that's what it starts to look like on the x-ray. It starts to look like a stick of bamboo on the x-ray, because the joints are all fusing. Signs and symptoms are typically vague spinal pain at night. Maybe the person feels a little bit better with exercise, but there's typically tenderness and spasm. Now, this is one of the big clues about sort of making a differential diagnosis between ankylosing spondylitis, which is an inflammatory disease causing back pain, versus mechanical low back pain. You were sitting in the car too long, or you lifted something at the gym, right? That's mechanical low back pain. Mechanical low back pain, what usually happens if you have mechanical low back pain, because I bet most of us have already had it, at least once, if you lie down, or at night when you lie down in bed, it usually feels what? Better, right? It's worse when you're bending, when you're lifting, when you're sitting too long, or if you lie down at night, usually people with mechanical low back pain will feel better at night when they're resting. People with ankylosing spondylitis, they'll have the pain at night. Sometimes it wakes them up at night. Sometimes they wake up in the morning with the pain. And that's because the inflammation is still going on, even at night. Treatments are anti-inflammatory drugs. In severe flare-ups, corticosteroids can be used. There are also corticosteroids are anti-inflammatories as well, but they're more powerful and also a little riskier to use. Maybe a spinal brace is needed, and sometimes surgical correction of deformities such as a spinal osteotomy and reconstruction is needed. Physical therapy interventions for ankylosing spondylitis. First is therapeutic exercise. Do we have? Nope. Okay. So therapeutic exercise, the focus is on promoting good posture and maintaining range of motion. What other things would the physical therapist do? Well, somewhat connected to therapeutic exercise would be postural re-education. Okay. So making sure someone is practicing good postural habits in good alignment. What other physical therapy treatments might be used? Anybody want to take a stab at it? Joints sort of becoming stiff, maybe not moving really freely. Stretching, okay, so stretching exercises, right? Maintain mobility. What's another thing we do as physical therapists, sometimes with joints that are stiff or limited? David?
Well, I was thinking heat. Applying heat.
Heat, maybe. So, heat. Or I would say in the patient with ankylosing spondylitis, whatever makes them feel better, heat or ice. Moderate amounts of either are probably not going to have a tremendous impact on the disease, but it might make them feel a little bit better. Brad? Joint mobilizations. Melissa, what were you thinking? Same thing. Tola? Same. Joint mobilizations, right? Getting our hands on them and trying to mobilize the joints to help maintain mobility. Patient education is also particularly important. Now, hopefully the physician is doing this, but inevitably we're the ones that are seeing the patients more often and usually having longer conversations with them. Most people with ankylosing spondylitis, they're going to be either on, in some cases, steroid, anti-inflammatories, but at the very least, NSAIDs, non-steroidal anti-inflammatory drugs. How do most people take, and if you've thought of this yourself, how do most people take NSAIDs? Motrin, Nuprin, Aleve? Like when it hurts, when you need them. Kind of on an as-needed basis. In someone with an inflammatory disease, that's kind of not very effective, right? You want, if someone has been advised to take non-steroidal anti-inflammatory drugs, or if they're on a course of steroids, they need to follow the prescription. They should maintain a steady blood level of the anti-inflammatory agent, right? Maintain a steady blood level. Even if it's not particularly hurting today, or even if I slept better last night, I'm gonna, for the prescribed period of time, continue taking the anti-inflammatory drug. Because if you only take it when you need it, then guess what happens to the blood levels on it? They go up and they go down. They go up and they go down. They're just really not going to do their job at mitigating the disease as effectively. Okay. So those are the physical therapy for interventions. This is normal posture, someone on the left, and then someone like poor old Aunt Mary, as her vertebrae became fused, she wasn't getting physical therapy. She wasn't getting postural education. She wasn't told to stand up straight. So her joints fused in sort of a bent forward position. Okay? And that was how the vertebrae were fused in her case. Do you guys might not remember, because it hasn't been on the radio lately. There was this public service commercial that was on the radio like a couple of years ago, but it started like this. It was like so haunting of Halloween. It was like this deep voice. Do you have AS? Right? And that was how the commercial started. Did anybody ever hear that? Do you remember that? Do you have AS? Well, Aunt Mary, like I said, Aunt Mary had AS, and maybe, who knows, are all those crazy things that have been happening today with the lights, with the bolster. Let's just go on to the next slide. Oh my God. All right. I did not put that image in this slide. Let's just get it over with. All right, let everybody nice and quiet. Can you pull that shade down a little bit? We gotta make it, because seances are usually a little better when it's a little darker. Now, okay, Aunt Mary, is that you? Are you trying to contact us from the other side, Aunt Mary? Please let us know. Oh my God, it's her, Aunt Mary! Oh my goodness. Now, people do say that there's a little bit of a family resemblance. I never really saw it myself, actually, but allegedly. But anyway, all right, let's on that note, guys, let's take and there's the bamboo spine. So a radiograph would look kind of like that. On that note, I think that's probably the end of ankylosing spondylitis. Oh, a little more. Bamboo spine, ankylosing spondylitis, stiffness, contracture, permanently bad posture now. Unfortunately, in this individual, it's not going to be getting much better. And on that note, we're going to take a break. So I will see you, let's say about a 7-minute break, and then we'll wrap it up with. So, a joint disorder linked to inflammation is a specific form of it is gout or gouty arthritis. Gouty arthritis is associated with a purine metabolism disorder. Purine, that's good, is a protein. That was you. That was not it, Mary? Okay, thank you, Melissa. Thanks for clarifying. Okay. And if you're having trouble metabolizing this particular protein, it can lead to hyperuricemia. Hyper, meaning too much of. Uricemia is an elevated serum in your bloodstream, uric acid level, right? So the uric acid levels start to go up. This happens in males much more frequently than females, 20-to-1 ratio. Typically men older than 40. And the most likely joint to be involved is the first metatarsal phalangeal joint of the foot, right? What people sometimes call the bunion, right? And there's a family history in 50% of patients, so there's probably implication there that there's some genetic predisposition. Precipitating factors could be infection of the joint, a lot of alcohol consumption, and rich foods that are high in protein and high in purine, injury, or exposure to cold. So let's say you're eating a high protein diet, you're chasing it down with a few vodka martinis, and you're out camping in Siberia, and you have a family history. And then all of a sudden, your metatarsal phalangeal joint blows up like an orange, right? It's warm, it's red, it's swollen, it's severely painful, or some other joint. It doesn't have to be the first metatarsal phalangeal joint, okay? How did that happen? Well, the uric acid floating around in your bloodstream, it started to gravitate toward one particular joint and accumulate in the joint and actually form crystals. Sodium monourate crystals accumulate in the synovial membrane of the joint. The synovial membrane doesn't like sodium monourate crystals in it, so it becomes very inflamed and it reacts to that. It's like a cellular irritant or a form of cellular injury. So tons of leukocytes, your white blood cells, will now go to the area to try to attack the crystals, but they also produce tremendous amounts of inflammation. So there's that inflammatory response that we talked to at the very beginning of lecture today. In this particular case, it's being triggered by the accumulation of the sodium monourate crystals. Does it make sense? Okay. Severe inflammation of the joint. Okay, the signs and symptoms are intense pain that worsens with any attempts at active range of motion, marked tenderness and redness and swelling, and possibly even having systemic effects of like a fever, and cellulitis, which is going to be redness or inflammation around the skin in the area of the joint. So not just the joint itself, but even the skin in that particular neighborhood. Okay? And some people have one episode of gout, they go to their doctor, they get it treated, it goes away, they never have gout again. Other people have reoccurring episodes of gout over the course of their life. And that increases the risk of tophi formation. Tophi formation are resisted sodium monourate crystals that form in clusters in the synovial membrane or the cartilage or in the subchondral bone or in the synovial sheaths around the tendons that are crossing over the joint, and you can't get rid of them. So you can sometimes see them, and you can sometimes feel them if you're palpating the patient. Typically, the tophi are going to be there after recurrent attacks when all of the crystals don't get resorbed, or not all the crystals go away. And tophi develop in about half of people who have recurrent gout. What are the interventions for gout? Well, anti-inflammatory drugs. Typically, they're going to just start with a course of steroids right off the bat because the inflammation is so bad. And then maybe move on to NSAIDs. Avoid purine-rich foods, such as organ meats like liver, kidneys, sweetbreads, and brains. Red meats, particularly bacon, beef, pork, lamb. Game meats like venison or buffalo. Any meats in large amounts. Anchovies, sardines, herring, mackerel, and scallops. Gravy and beer. So sorry if some of your favorite foods might be on that list, but all of them. Have you had gout yet? But those are foods that are very high in purine. Now, in medieval times, who came down with gout? It was the noblemen, right? The kings and the princes and the princesses that lived in the court. The peasants living in the village never got gout, right? And it had to do with their diet because the peasants couldn't afford meat and these rich foods and fancy beers and fancy seafood. The peasants were just trying to get by, eating potatoes or some grains or whatever they could manage to live on. Okay, so gout was historically known as sort of a rich person's disease, right? Now, today things have become a little bit more equivocal in our diets. Even people who are facing financial hardships are often eating a lot of red meat and eating things that might be high in purine or protein. So anyway, but just a little history there about gout. For chronic and recurring gout, for people that are having multiple episodes, they can actually take a drug potentially for the rest of their life to control their uric acid levels on an ongoing basis. Right? So you can sort of take a uric acid level minimizer drug if you need chronic prevention. And you'll read about that in the homework assignment. That's going to come up in the homework assignment. All right? Okay. So here are some images of joints with gout. First, metatarsal phalangeal joints, obviously even more severe on the left. You can see it results in destruction of the joint cartilage, deformity of the joint, and enlargement of the joint that might remain even after multiple episodes. What you'll often see in people that have had reoccurring gout in the same joint is not only the tophi formation, but a residual enlarged joint. Right? So not a whole lot of fun to have. Here are some images of tophi. In this case, you can see them around the pinna of the ear. Here, 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 here. Right? So those are uric acid, sodium monourate crystals that have formed under the skin. And here around the person's elbow, in the tissues surrounding the joint, there are multiple tophi that have formed. Okay, scleroderma. We'll go over a couple more inflammatory disorders. This is progressive systemic sclerosis. And remember what sclerosis generically kind of means is like excessive like thickening or overgrowth, right? In this case, the etiology is unknown. It occurs more in females at a 4-to-1 ratio. The course of the disease is very very unpredictable and highly variable. Remember, sclerosis means kind of thickening or overgrowth. So what do we see with this? Diffuse fibrosis, degenerative changes in the skin and joints and internal organs, thickening of the skin. It's first noticeable in the hands and in the face. There might be pulmonary and cardiac complications like arrhythmias, pericarditis, lung fibrosis, pleurisy. That's going to lead, those things can very easily lead to pulmonary hypertension. You often see people having polyarthralgias, multiple joints aching, GI disturbances, and even kidney problems like renal hypertension. Now for people that have scleroderma, the treatments are steroids for acute episodes, plus any medications that are needed for specific organ involvement. I'm trying to just sort of control that inflammatory response in that individual with a healthy lifestyle. This is, photograph is a little misleading. This is someone's hand. It looks like their fingers have been amputated. They haven't, it's just that their fingers are bent. So you're only seeing their proximal phalange. The rest of their finger is just curled underneath. But what it's pointing at is the thickening and the fibrosis, right, of the skin and around the margins of the joint. And here you see thickening and fibrosis of the skin around the mouth. So much so that that person is now having difficulty closing their mouth, right? The skin has kind of become thickened and fibrotic and is like pulling away from the actual orifice. Okay, going on, fibromyalgia, another chronic inflammatory disorder also known as fibromyositis. This is idiopathic, meaning we pretty much don't really understand why it happens. Usually in females, precipitating factors may include stress, emotional stress is what I mean there, not the kind from kinesiology and biomechanics, but the emotional kind. Trauma, sleep disorders, rheumatoid disorders, infection, sleep disturbances that don't allow for the normal healing of daily stresses on tissues. All day long, even if we're not doing any particularly aggressive sport or working really hard, all day long we're loading our tissues. Even if we're just sitting, we're writing, walking around, there is strain on our tissues all day long. There are muscles that are being loaded and contracting in different ways all day long. At night is when they all get a break. And it's when you're sleeping at night that tissues sort of restore and any micro damages will heal, right? So guess what happens if you're not sleeping well? Tissues don't restore and they don't recover fully. So then you start feeling not so well during the day. Your tissues never really got a chance to completely bounce back. The signs and symptoms are achy, widespread diffuse pain that tends to move around from one area or one joint to another over time. One day it's my shoulder, then a couple weeks later my elbows started hurting, and then my knees. Localized tenderness or spasm with whatever joint is bothering them. Pain is easily provoked by overuse or activity. And this is a fairly common condition. I would say to you that scleroderma that we were just talking about, my whole career, I've only seen and met a couple people with scleroderma. Fibromyalgia, dozens, right? Diagnosis is made by if you have at least 11 of these 18 tender points are palpable upon palpation. So the blue dots are the 18 points. You can see where they are, right? What you do is you put your thumb on the point, right? And you palpate that spot, and you have to make a subjective determination, is it particularly tender? Now, remember, if you push on anything hard enough, it's gonna hurt, okay? So you have to use sort of a normal amount of palpation pressure, and you have to know in what your expectation is on yourself or another person. That amount of pressure normally wouldn't hurt. So you have to kind of learn how much that is, okay? But on a patient with fibromyalgia, at least 11 of these 18 points, or more than 11, are gonna be tender. Widespread pain present for at least 3 months. There is a fibromyalgia impact questionnaire, just this is mostly FYI, but there is actually a tool you can use if you want to kind of get a measure of how much fibromyalgia is impacting someone's health and life and function. There's a specific tool just for that. And then what you could do is if you have someone with fibromyalgia and you gave this to them at the start of therapy, then you could give it to them again 4 weeks later and see if their score is improving. Right? Is their function getting better? And this is just some more information about that tool. I'm not even really going to go over this slide. If you ever want it, there's a link to it there. And this is a slide that tells you how to score it, what the numbers actually mean. Is a high score the best possible score or the worst possible score? So if you need that information, it's on this slide. And I'm not going to, that won't be on the exam. Sometimes fibromyalgia just spontaneously resolves. It burns itself out. The person feels like, yeah, I feel okay now, I'm better. But in many people, it's chronic, and it just won't seem to go away. What can we do? Aerobic exercise is an evidence-based effective therapy for people with fibromyalgia. You might think, well, why is that? Well, I don't know exactly why, but I'm going to speculate. Remember that one thing that drives fibromyalgia is chronic inflammation, stress, and poor sleep. Regular aerobic exercise helps mitigate all those things, right? It reduces your stress level, makes you feel more relaxed, it makes you feel more tired at night, so you sleep better, and regular exercise also has an anti-inflammatory effect systemically. So for those reasons. And then anti-inflammatory drugs, analgesic drugs, antidepressant drugs, because many people with fibromyalgia are also depressed. Remember that depression is also linked to systemic inflammation. All right? And then treat local symptoms as needed with heat modalities and massage. What I will caution you, though, is it can sometimes be a little frustrating with patients that have fibromyalgia if you're not really appreciating the big picture and you're only doing local treatment. Because what you're going to end up doing is just jumping around all over the course of weeks. You'll be treating their elbows, then the next time it's their low back, and then it's their knees, and you just sort of feel like you're following their symptoms around all over the body. And are you really doing anything of particular value, or are you just sort of giving them palliative relief of wherever their symptoms happen to be on that day? And not that that's not okay, but don't forget about the number one biggest and most effective intervention, which is going to be aerobic exercise. Okay, lupus, erythematosus. This is a chronic inflammatory connective tissue disease of unknown cause. Patients experience periods of exacerbation and remission. There is a genetic or hereditary component. It can also affect the joints, the kidneys, the vessel walls. 90% of all cases are in females. And the signs and symptoms are fever, malaise, again, basically malaise means just feeling like crap, headaches, polyarthralgias, and a malar butterfly erythema. And I'll show you what that is on the next slide. It's a rash on the face that looks like a butterfly landed on your face and left sort of a rash in that shape. Skin lesions of the face. Alopecia. Does anybody know what that is, by the way? What's alopecia? Melissa?
Like loss of hair.
Yeah, it's when your hair falls out. And some autoimmune inflammatory disorders cause your hair follicles to shut down and your hair falls out. Pleurisy, pericarditis, central nervous system and renal disorders. Interventions are drugs to either control inflammation, like steroids and anti-inflammatories, but then also drugs that are immunosuppressive. And those are the kind of, right now on TV, there are a lot of commercials for a drug, and I can't remember the name for it, but it's used for psoriasis, right? And there's this commercial for, if you've got patchy psoriasis, there's this drug, and then in the commercial, it goes like over all of the side effects. Like, but if you take this drug, you might get a bad infection and you might die. So, but it does work because what it is, it dampens your immune response. It can be used in things like in lupus, in psoriasis. But there are drugs that dampen your immune response. But the risk with that is that when you dampen your immune response and your immune system activity, then you might be more vulnerable to infections, right? So those drugs have to be used very cautiously and carefully, and those individuals have to be monitored very closely. Here's the malar butterfly sort of shaped rash, like butterfly wings sort of on the face, right? And also some other red spots, pink spots, changes in the skin that are sometimes seen in lupus. Well, a lot of people with lupus will actually die from cardiac complications and the effects on the heart. Okay, so let's do a little clicker action here. Which is true about lupus? Patients with lupus erythematosus should get lots of sun to help clear up their skin, or it is more common in men and in children, or there are interrelated immunologic, environmental, hormonal, and genetic factors involved. Only one of those things is true. You could discuss if you want with your neighbor to vote, or you could vote. You could arm wrestle, you could debate, discuss.
I think it's just me, honestly.
What is the PTS?
Spiral fracture.
What's PTS?
I
It's
don't
on
know,
YouTube?
patience, I guess.
Oh yeah.
If you find it, send me the link. I'll put it in that lecture in K&D for week 1 next year. Okay. Overload in a torsional direction. Yep. Surpassing the ultimate failure strength, the road to failure strength. Okay, oh, let's look at what the answer was. Okay. Where are the answers? Very good. 100%. Awesome. Okay. Hopefully a harbinger of things to come when you have the midterm exam in this course. Not too far away. Remember, guys, so now that we're several weeks into this course, remember there's a lot of information. There's a lot of terms, there's a lot of words, there's a lot of things, right? Quite frankly, none of it's really rocket science. None of it involves like calculus or really abstract thinking or really unbearably complex conceptual models or frameworks. It's all pretty much straightforward, but there's a lot of it. So stay on top of it, okay? Don't save it all up for the night before or 2 nights before the exam, because in a course like this, that's kind of a recipe for disaster, okay? And you don't want to spend the rest of the semester worrying about whether you're going to be able to dig yourself out of the hole from the midterm, right? So if you're prepared, you'll do well. And there are absolutely, definitively, I can tell you that there are people who get high 90s on the midterms in this course, right? And those are the people that stayed on top of the material and made study cards, flashcards, and were really ready for the exam. It's just a lot of information. It's a lot of words. Okay, Paget's disease, also known as osteitis deformans. Just call it Paget's disease. Now, here's the thing. This isn't really an inflammatory disease, but I couldn't figure out where else in this entire course to talk about it, so we're talking about it today. It's a disseminated bone disorder of unclear etiology, possibly associated with a virus. And what happens is your bone cells start misfiring like crazy, both your osteoblasts and your osteoclasts. Now, in different proportions in different areas. If your osteoblasts are overproducing or overworking, what's going to happen if your osteoblasts? Extra bone, more bone. If your osteoclasts are working extra, what's going to happen? Bone destruction, take bone away. So you see a mix of both going on in different areas of the bone in these individuals. And of course, there are going to be deformities. If there could be degenerative joint changes, because obviously for your joints to be normal, it's somewhat predicated on the bones that form the joints to be normal. And the joints can, the bones can also, because they are vulnerable, they might be more likely to pathological fracture. The signs and symptoms are that the thickening of the bone typically occurs first in the tibia, the femur, the skull, the pelvis, or the vertebral bodies. So there's often a thickening that occurs. And on this bone scan, you can see in the cervical spine, thoracic region, the pelvis, the left femur, both tibias, both wrists, all that like increased signal from that bone in sort of somewhat asymmetrical, a little bit all over the place, like a little unpredictable what bones are going to be involved. Person's going to have pain and functional limitations due to these complications of the skeletal system. Medications are used to control osteoclast activity. So there are drugs like that can be used to kind of inhibit osteoclasts, and specific interventions for complications, like if there's a pathological fracture, then that's obviously got to be managed. Okay, so one of our last clicker slides of the day. Bone changes are the only clinical manifestation of Paget's disease. Now, is that true or false? And it's a little bit of a trick question, so I will tell you is that the only ones we've talked about so far are the bony changes. So you might think that that means that bony changes are the only clinical manifestations of Paget's disease. However, the answer is false, okay? The answer to this question is false. And that is because people with Paget's disease will also have often changes in the skin. You can see this, there's a famous medieval painting called The Ugly Duchess, and it's speculated today that this woman probably had Paget's disease, right? Due to the underlying deformity of the skull and then the changes in the skin. And there can also be involvement of internal organ systems. So it's not just a bone disorder, it can affect other tissues as well. You can see the person's thighs. Left leg looks relatively normal. Right leg, something really weird going on here in the thigh. Probably, in this case, it's thickening of the bone of the femur due to Paget's disease. The deformity and the thickening of the facial and the skull bones that lead to disfigurement and deformity of the face. Pretty rare. I've never seen a patient with Paget's disease, right? And it's not something you're likely to see, but it's kind of important to know what it is, just in case you ever do. Okay? Oh, this slide we don't need. Okay? But if you did, just in case you ever want to go again in a group, how much would you need to bring if you were going in a group to the Mutter Museum? $5, $10, $15, or $1 million. So the group rate. So anyway, if you go to the museum on your own at any time, individual entrance is like $18. But if you're in a group of 10 or more people, you can get a discount for $10. And sorry, I forgot to actually just take that slide out. So I will see you next week, guys, in Philly. I will probably just meet you at the museum. You do have an assignment to do, so let me talk about this for a second before you leave. What's going to happen is you have to be there by 1:45 so that we can start the tour promptly at 2. We're going to divide into two groups. And I'm always going to be downstairs, and Marcy Engelman, the director of education, who normally doesn't even give tours, she's doing it as a special favor because she's so great. I specifically request her. She's going to have the upstairs group, and then after a half hour, the groups are going to move, and Marcy and I are going to stay on our respective floors. So you'll all experience a half hour with me, and you'll all experience a half hour with Marcy, and we're gonna kind of show you some highlights. I'm gonna be focusing on musculoskeletal pathology, obviously, right? Because that's really the main motivator for this trip. But there is an assignment, and what you have to do is bring a little tablet or a notebook or something you could write on, and a pen or a pencil, because you've got to, throughout your touring around the museum, find a disease or a disorder or a condition of the musculoskeletal system, right? Because Medcon Rehab 1 is the musculoskeletal Medcon Rehab. And it's one that you don't know too much about or that really gathers your attention. And you can make some, you know, if you want to jot down whatever notes you have about it at the museum, you can. But what you're going to do is basically find a topic, right, for your mini paper that you have to write. And the paper is due a month later, and the guidelines are on Sakai. What you're basically going to do is you're going to pick a musculoskeletal disease or disorder or condition that you don't know a whole lot about, that you find interesting, and that you'd like to learn a little bit more about. And then you have to find a couple resources and references, and you have to look it up, and you have to, in the paper, it's very specific. The guidelines for the paper are very specific. You have to tell me the etiology or the cause, if it's known, right? You have to tell me like risk factors and prevalence, if it's known. You have to tell me what's the medical management. How does someone with the disease treat it, right? What you have to write in the paper, and you're not writing the paper on Wednesday while you're at the museum. You do that after the fact. The only thing you have to remember to do while you're at the museum is just jot down some different topics, some things that you see that we talk about or that you discover on your own, and then maybe afterward you decide which of those you're going to pick for your topic for your paper. And it's a very short paper. 5 pages total is the maximum limit, but one of those pages is the cover page, one of those pages is the references. So the actual paper itself is a 3-page max, 12-point font, double space. So it's not you're not writing a big dissertation here. It's a short paper, and it's very structured. What I want you to put in the paper is very structured, and that's in the guidelines document that's on Sakai. Does anybody have any questions? Does anybody have any questions about how to get into Philly for the Moon Museum? There are lots of ways to do it. In fact, the public transportation directions are on the document on Sakai. There have been years where everybody goes as one big group on the Patco train, right? You can, squeeze 5 people into an Uber maybe, or you could drive. There is parking on the street, but it's metered. So if you can find a spot, and it's I think you get 7.5 minutes for a quarter. So it's like $2 an hour for the parking meters. There are parking lots, but they're pretty expensive. If you park in a lot or a garage, you're going to be dropping like $20-25. So public transportation, you're going to get there. It's not too expensive. That might be a good way to go. You can get there however you want. Just make sure you're there by 1:45, and I'll meet you in the lobby. Okay? Anybody have any other questions about, or comments, or feedback, life in general? Go ahead, Kyle.
I was just going to say, if you drive into Philly, their meters take the Park Mobile app, so you don't actually have to feed it with quarters. You can just pay with your phone, and then update more time.
Oh, okay. So you don't even need to go to the meter or the kiosk? It's the Park Mobile app. Cool. That's good to know. I didn't know that.
They have one because you're from Asbury Park, right?
Yeah,
They have
do.
Asbury Park.
Uh-huh.
That one's good too.
Yeah. There's a big music festival going on in Asbury Park this weekend, actually.
With Jack Johnson and stuff, right?
Yeah. Blondie, all these other surf bands that I've never heard of. Yeah. It's right across the street from our building that we're in. Like literally, like across the you can look out the windows. Just watch from there.
I'll see you there.
Oh, cool. You gonna be there? Oh, good. Okay.
We have 4 exams to study for, so.
You do? Next week? Okay. All right. Well, make sure you study too, okay? Go ahead.
Can we bring drawstring size bags into the museum, or does everything have to be put into a locker? Can we not carry anything around?
They don't really want you carrying like a backpack or even like a bag into the museum. But there are lockers that you can fit a backpack in.
and they're a quarter, but you get the quarter back when you're done. Right? So it doesn't even, it's really a free locker. But you have to have a quarter to make it work.
Okay, because we'll be coming right from class, so I wanted to.
Yeah, just throw your stuff in a locker. And the reason is because a lot of the cabinets are flat and they have glass on top, and they just don't want any glass breaking, and they don't want people banging things around and all that sort of stuff. There's a lot of very delicate things. Yeah. Any other questions or comments or concerns? All right. Sounds good, guys. See you later.
I'll get some food, baby.
I might eat here and then go to the library. Right?
I don't know why everyone's asking.
What exams do you guys have?
Yeah, I figured I'd just ask about the bag thing, because I know some people could probably just drop their backpack after the test, but I'm sure they'll go right to the station.
Do you have an exam on Thursday?
Are you going in? I think,
Monday,
do they have
Wednesday.
class? Make sure you do.
So it's like your culture can be a nice break. And then you can bring it back. I mean, the tours at 2, we'll be done with the tour. Get home and start studying.
I'd also like to try to get a lot of early.
So if it's a nice day, you would take it all the way to the very last stop, which is 16th of August. And from there you just walk. It's about a 12-minute walk to 22nd. If it's raining, you can actually get to within a half a block of the museum. But you have to, in that case, get out and pack a Nathan Market. That's the first stop in Philadelphia. And then you have to get on 2nd, Market Frank Hotel. And then you have to get on a trolley. It's like a little more complicated. But the step-by-step instructions are all in Chicago. But if it's not, don't do that unless it's pouring rain. If it's not pouring rain, just take Patco to 16th and Locust and then walk. Yeah. It's a nice walk. You walk right through Rittenhouse Square and then turn right.
Tori, are you staying in here? Can I leave my stuff or no? Yeah.
All right. Okay.
Christine, you don't come in here, right?
Hi, David.
I'm just wondering what's I'm trying to figure out what are psychosocial factors. What are considered as psychosocial factors? Psychosocial. It's from like a few lectures ago.
Factors in what?
What's it called?
12:30.
Musculoskeletal work-related disorders.
Oh, right.
I know.
What are the psychosocial factors in work-related musculoskeletal disorders? So specific examples would be one risk factor for developing a work-related musculoskeletal disorder is like job dissatisfaction, chronic burnout, high anxiety or depression levels associated with your job. You hate your boss, you're unhappy, your coworkers are bullying you, they're mean to you. Those general psychosocial stress factors can cause inflammation. And then if you've got some repetitive motion injury going on, they can be like interrelated triggers.
I think I made it Monday.
Okay, so those are that's what you meant by psychosocial factors?
That's what I meant.
Oh, okay, I was trying to figure it out. I drove myself mad.
Yeah.
All right, thank you.
And they can also be, quite frankly, non-work related psychosocial factors. Like let's say your job is actually fine. You love your boss.
Yeah.
You're happy with what you do, but you're fighting with your wife. You hate your kids. You just totaled your car. So psychosocial stress outside of work can kind of maybe can be a factor as well.
Oh, okay, I see.
Yeah.
Okay, thank you.
Yeah, absolutely.
Did you see Christine?
Hi, Christine.
What? Hi.
How are you?
I'm good. How are you?
I'm well.
Do you need any tasks done today before? I'm good.
How are you? Huh? It's good. It's just we have 4 exams next week, so like yeah. So we're everything pretty much except for K&B practical and Medcon, which is yeah. We're going to the Meter Museum halfway through the week, so everyone's like how are we gonna do this? Because we're gonna have to go for like 4 or 5 hours to the so I'm definitely it's prep time.
Oh, you know, living the dream. Yeah. I'm going to a wedding tonight, maybe I'll do some grinding there.